This conference will now be recorded.
Hello people, welcome to class. So as a new update has come in the chickenpox guideline, so I just got request to take a class. I'll be highlighting the guideline. What are the important updates are there, okay? Now, just a brief. So chickenpox or varicella is a primary infection caused by varicella zoster virus. In pregnancy, it may cause maternal morbidity or mortality. In baby, why we are worried? Because baby can get fetal varicella syndrome or neonatal varicella also. So both identities are different. Okay, fetal varicella syndrome is a congenital defect that occurs if the woman will get a chickenpox within first 28 weeks, and neonatal varicella is like adult varicella that will happen when the baby is born. And so herpes zoster virus, DNA virus from the herpes family, highly contagious, transmitted by respiratory droplet infection or by direct personal contact with vesical fluid. That would be direct, and indirectly it could be from fomites such as skin cells, hair, clothing, and the bedding. So it's a very high contagious infection. Okay. Now, primary infection usually how the patient would present to us would be like there would be fever, malaise, pruritic rash, rash usually of chicken pox. It appears in crops, and it is a like a maculopapular. First, it is a small maculopapular rash. You can see in this picture that this small one are the maculopapular, but later on it becomes viscular. So this vesicle, you can see this vesicle. This vesicular rash is a characteristic of chickenpox, and usually where it comes in crops. So various stages of the vesicles can be seen, and then it would crust before it heals. Incubation period is like 1 to 3 weeks. This is most important us to know that what is the infectious period, because mostly your questions will be like depend on that. The patient would be infectious 48 hours before appearance of rash, and patient would be infectious till the crust is formed. Usually forming of crust will take 5 days. Okay, so the person is infectious before even the appearance of rash, that is 48 hours before. Now, it is a common childhood disease. In childhood, it causes milder form of infection. If it occurs in adult people or pregnant, then it would be a serious infection. And in UK, usually more than 90% of the people over 15 years of age would have immunity already. So if their blood is checked, they will have varicella zoster immunoglobulin IgG antibody. But the people from tropical or subtropical country less likely to be seropositive. They are more susceptible to having chickenpox infection in the pregnancy. Now, so when the first episode occurs, that would be chickenpox or it would be varicella. But this virus usually it remains dormant in the sensory nerve root ganglia. So it will remain in the sensory nerve root ganglia. The virus is not going anywhere, and any of the time when there is a low immunity, that time it may be reactivated. That time skin rash occur, and it usually occurs in the dermatomal distribution. That means it will only happen in one dermatome that is supplied by a single nerve. And another thing, it will never cross a midline. So this is, you can see the thoraco, like one of the thoracic nerve has been involved, and the rash is in the distribution of that nerve. This is a characteristic feature of herpes zoster. Even, you know, uh, like you might have seen the adult patient, they come to your clinic, and many of the time the people, they are unable to diagnose this. Though I have seen many cases, it is a very characteristic that all vesicles it will be very painful, because the neuropathic pain occurs, and it will be in single dermatoma of a nerve, and it will never cross our midline. Okay, so keep eye on in your when you see such kind of patient in your clinics. So, like if a person risk of infection will be, though when the herpes zoster occurs, it is a secondary infection. The person would have an antibodies already. But if it occurs in non-exposed area, then also spread can occur, such as thoracolumbar. And if it occurs in like in immunosuppressed persons, such as ophthalmic, that time even disseminated infection can occur. So usually the secondary infection is mild, but in cases of immunosuppression or some kind of situation, it could be severe also. So if a person having herpes zoster or shingles, that is in the covered region, usually the person will not be infectious. Now, what can be done, what we can do to prevent it? So it can be done by giving vaccination against varicella, either prior to pregnancy or in postpartum period, if the patient is seronegative for varicella zoster immunoglobulin. And though universally in UK, testing for this is not done, but anytime in the pregnancy, if the testing is done and the patient is susceptible, postpartum immunization with the varicella can be done. And this is a new thing added, new update in this guideline. And post vaccination, there is no issue, the woman can breastfeed child without any health concern. Now, if the vaccine is given, then incidence of primary infection will fall by 80%, and mortality related to this condition will decrease by two-thirds. These numbers may be necessary to remember by part 2 people. And the immunity for the vaccine remains for at least 20 years. Two types of vaccines are used in UK. These are Veriverex and Verilix. Okay, so I have shown you the picture of Veriverex. These are live attenuated vaccine. As these are live vaccines, because of that, we cannot uh, offer the woman while she is pregnant. Usually, the two doses are given, and these doses are 4 to 8 weeks apart. Now, if a reproductive age woman has been given vaccine, so advice is given not to get pregnant 4 weeks post vaccination, till after the completion of the vaccination schedule. So these are a few updates so that you should be aware of. Postpartum vaccination and pre-pregnancy vaccination, everything what related to vaccination has been added new in this 2024 guideline. Now, what the guidelines say, when the patient comes in the antenatal care first time for booking, that time, routine checks are not done. The patient should be taken history about vaccination, possibly having chickenpox or shingles infection. Now, if the patient had not been exposed, that means she would be considered to be susceptible. She should be advised to avoid contact with anyone having chickenpox or shingles, because she would be susceptible, she can get it. 95% of those who reported previous chickenpox infection would have antibodies. And yeah, the individual born and days, that I have already told, that the people those who live in the tropical and subtropical countries, more likely they will not have antibodies, and they would be seronegative, they would be more susceptible. Now, if the now second scenario, the patient already got contact and she is pregnant, so what will be the next thing? Next thing, we have to take careful history. We need to find out whether the woman uh, is susceptible to get infection or not. So we have to take careful history of previous infection of chickenpox, or whether she has got vaccination, or otherwise we have to ask what type of varicella zoster infection she has been exposed to, what was the time of exposure. That means whether the rashes was crusted or not. If she has exposed to someone when the rashes are crusted, then she's not at risk. Then the closeness and the duration of contact. So this would be necessary. Now, what is the time of exposure? It significant exposure. It could be continuous, like a patient has gone to a family of some person, and anyone having that chickenpox. So there is more than one exposure, or you can say the continuous exposure. So more than one time, the person is getting coming in contact. Okay, so this is significant exposure. Single exposure to infectious shingles. Shingle I already told. Those if it is exposed on a exposed area. Now, closeness of contact, significant contact, when even the people were in the same room for 15-minute time, they have face-to-face contact, or contact in the large setting such as open ward. Previous guideline, it was there face-to-face contact for 5 minutes, but in new updated guideline, they have removed that 5 minute. Now the significant contact will be contact in the same room for 15 minutes, face-to-face contact without any time limit, and contact in large open setting. So with this, you can get to know whether the patient is susceptible, like she has got contact, whether it is a significant contact or not a significant contact. Now, if the patient, after contact history has been taken, then if she says, "No, doctor, I have got chickenpox or shingles," that time, or she has received vaccine, if she's sure about it, then we are not worried, because she would be having protective antibodies, so she would be immune to varicella infection, so which we just can reassure the woman. But there could be possibility the patient says, "No, I'm not aware of it, I'm in a doubt." That time the blood test would be sent, and the blood test is varicella zoster IgG antibody test. Okay, this is the common question come in part 2 and part 3. Many of the time the people will still make mistake. Many of the time people will say IgM antibody, but that is a recent infection and we want to know the old infection. So we have to test for varicella zoster immunoglobulin IgG. Okay, so this would be your answer. Then this is again a new update in the guideline. Previously, they were checking whether the immunoglobulins like IgG uh, is present or not. If it used to present, then they used to reassure. Otherwise, they would give prophylaxis, post-exposure prophylaxis. But now they have given us a number. So if the patient has got varicella zoster IgG either negative or less than 100 international unit per ml, in that situation the patient would be at risk and we have to offer her post exposure prophylaxis. But if a patient is if the patient has got immunosuppression for reason other than a pregnancy, in that situation, uh, if the varicella zoster is negative or value is less than 150, they should be considered as a candidate for the post exposure prophylaxis. Okay, so these are the few things. These are different and updated in this new guideline. Okay, now what now there is a changes here in this slide also. If the patient is not immune to varicella zoster virus, or she has got significant contact, then she should be offered what? PEP, that is a post exposure prophylaxis. Now, what are the choices? So, there is a change in this guideline. So, choice number one now is acyclovir 800 milligram 4 times daily from 7th to 14th day of exposure. This is the choice number one. Second choice would be valacyclovir, 1000 milligram, 3 times daily from 7 to 14 days of exposure. So previously these tablets were not there. They have been added in this new guideline only. So this you have to remember. It's a very important point that can be asked in 2 and 3, part 2 and 3, both people. Now, adverse effect of acyclovir could be headache, dizziness, nausea, vomiting, diarrhea. Now, another few things that you have to remember: if a patient has impaired renal function, or if the like mm, in that time there would be change in the drug dose, or it would be reduced, or sometime the drug may not be completely absorbed if the patient has bowel problem or inflammatory disease. Okay, these both drugs are given to the pregnant woman, um, to prevent from chickenpox to happen in the pregnancy, but they are not licensed in UK to be used under pregnancy, but still they are considered safe and recommended by PHE and UK HSA expert working group. Okay, so these are the updates in the new guideline, and you have to kind of know this. So for the now remember the dose of acyclovir, here it is 4 times. Okay. So why it is important to highlight this, I'll just tell in upcoming slides. Now, if the patient is not, if there is a contraindication to antivirals, or patient says the patient doesn't want oral tablets as prophylaxis, then what to be done? In that situation, second choice can be used, and the second choice that can be offered to the woman as post exposure prophylaxis is varicella zoster immunoglobulins. Okay, so this is the second choice. This is a change in the guideline. uh, Now first choice is acyclovir and valacyclovir oral tablets from 4 to 7 to 14 days of exposure. That new change uh, is there. Now if first they will be offering tablets, if the patient doesn't want or any adverse effect, then varicella zoster immunoglobulin will be given. So it will be like given, if it will be given um, as soon as possible, usually within 10 days of exposure, and or within 10 days of appearance of rash in the index patient. And when the patient is given immunoglobulins, then she would be considered as infectious. So from 8 to 28 days after they receive immunoglobulin, and from 8 to 21 days, that means 1 week to 3 weeks after, if they have not received varicella zoster immunoglobulins. Okay, so this part is kind of same, so there is no change here. Now, what could be the adverse effect? There could be pain and erythema at the site. Risk of anaphylaxis is very small, that is 0.1%. Patient with IgA antibodies who already receiving replacement therapy, for example, patient having hypogammaglobulinemia, they usually don't require immunoglobulins, and they are more increased risk of anaphylactic reactions. Okay, if the patient has a repeated exposure, like uh, if exposure to chickenpox further occurs second time, now we and seroconversion has not occurred, then second course of oral tablets can be given 7 days after exposure. So this also can be asked, that the patient has taken oral tablets, again she got exposed, then you have to check blood. Why? Because you have to see whether the seroconversion has occurred or not. That means the patient has got varicella zoster immunoglobulins or not. If after second exposure also the patient blood comes negative for varicella zoster immunoglobulins, that time second course of antiviral can be prescribed from 7th day after second exposure. Okay, and if this is for the tablets, and for the immunoglobulins, If it repeated exposure occurred within 321 days or more after last dose, then also varicella zoster immunoglobulins can be given. Is it clear, people, this point? Is it clear?
Yes, ma'am.
Okay. The woman who had exposure to chickenpox or shingles, or they have not received acyclovir or immunoglobulins, n- like they should notify the doctor, maybe their GP or midwife when the rash occurs. Another thing that you guys should remember, and you should know, that once the patient developed chickenpox, that time giving varicella zoster immunoglobulins will make no sense. Okay, many of the time, you know I have seen people making this mistake. In the choice, they will give varicella zoster immunoglobulin if the patient developed chickenpox. So please understand, the validity and use of varicella zoster immunoglobulin is lost once the patient already developed symptoms of chickenpox. So please don't give it, and remember this also, because many of the time people will do mistake here. Okay. Now, what could be the maternal risk and what could be the fetal risk? Maternal risk, it can, varicella infection occurs in adult, it can cause pneumonia, and the incidence you have to kind of remember, for part 2 people minimum 10 to 14%. There could be hepatitis, there could be encephalitis, and pneumonia is more severe during the later gestational ages, because the uterus may have an effect on the respiratory system. Now, what could be the fetal risk? Fetal risk, um, the risk of miscarriages doesn't appear to be increased if the woman got varicella in the first trimester, so it's fine. So in part 3, people, usually the role player will ask this question: would I miscarry? And your answer would be no. Then seroconversion, if occurs in first 28 weeks, they can develop congenital varicella or fetal. Nowadays, it is called as fetal varicella syndrome. It usually occurs less than 1% of the patient. And what can happen? Fetal scars formation in dermatome distribution, eye defects, that means macrophthalmia, chorioretinitis, and cataract. There could be hypoplasia of limbs. Usually, hypoplasia of limbs or limb reduction happens only in this syndrome. So that would be sort of a keyword for you for the answer. There could be neurological abnormalities, microcephaly, cortical atrophy, mental retardation, dysfunction of sphincters. Okay, this you have to remember, part 2 people and part 3 both. Part 3 people, you can get viva question where they ask this. Part 2 people, you can get any EMQ and SPA. It usually doesn't happen in the first infection. It happens when the subsequent herpes zoster reactivation occurs. So it happens in minority of the babies, less than 1% only. So if the woman get varicella in what to be done? So she can be referred to fetal medicine unit for discussion in the detailed ultrasound, either at 20 to 80, 16 to 20 weeks of pregnancy or 5 weeks after infection. Why? Because by that time, uh, the amniotic fluid may be formed, and viral markers they can find from the immunosynthesis. Because of that, it is either at 16 to 20 weeks or 5 weeks after infection. Usually, if they wish, then they can do fetal medicine people can do immunosynthesis. They will, basically, they want to find out whether DNA PCR, that varicella DNA is there or not. If it is negative, then the woman can be assured, because it has got very strong negative pre-predictive value rather than the positive. Now another time you will ask, get the question, when the immunosynthesis to be done, it to be only done when the lesions are completely healed or crusted, because that time the mother will not be infectious in at all. Okay. Now, this is very important. You may get this in the Viva question also, that uh, how to manage a woman who got chickenpox in the pregnancy. So, what to do? So, first of all, the woman who got chickenpox, they should do the notification to their GP. Women should avoid further spread, so avoid contact with the susceptible individuals, other pregnant women and the small children, unless the lesions are crusted. Then uh, symptomatic measures for hygiene to be advised so that secondary bacterial infections will not happen. Oral acyclovir is prescribed if they present within 24 hours of the rash, and if they are 20 weeks plus or beyond of the gestation, use of acyclovir before can be considered. Now remember the dose here. Now, when we were doing using acyclovir for uh, like is when we were used for exposed exposure prophylaxis, that time dose of acyclovir was 800 milligram 4 times daily 7 days. But now it is not, no more prophylaxis, it is a treatment. So treatment dose is 5 times, so 800 milligram 5 times daily for 7 days. And valacyclovir is also given. They're not licensed in the pregnancy, that we know. If you have the patient under discussion having severe chicken pox, that time even IV acyclovir is given. Again, I'm repeating the same thing, that once the woman develops chicken pox, please don't give varicella-zoster immunoglobulins, because that time there is uh, like no therapeutic benefit. So patient will not get any benefit, because that was the varicella zoster immunoglobulin is given as a prophylaxis to prevent full-blown infection. But now the infection is already there, so there is no role of varicella zoster immunoglobulin. Here I have just made it separate differently, and because many of the time, even, I have seen the people making mistakes. Now there are two identities, people, please understand. There are two types of symptoms. Ones are the indication, where the patient would require admission in the hospital with like intensive care unit. Wo- what are the indications for that? Now, if the patient has got respiratory symptoms, if the patient has encephalitis, and the neurological symptoms such as photophobia, seizures, drowsiness, if the patient has got severe heavy rash, hemorrhagic rash, if the bleeding or dense rash, uh, that these are the situation where the potentially threatening chicken pox. So if your patient has got all this, that time patient would be admitted in the hospital, and ideally with the ICU facility. Okay. Now, another situation, the patient would require hospital assessment. The patient has got no complication, but hospital assessment would be required. Which conditions? When the woman is a smoker, she has got COP, chronic lung disease, or she is immunosuppressed, that means taken steroid in last 3 months, or second half of pregnancy. So, as recently few exams, this chickenpox station is coming, and because of that, I know that people make mistake. So whenever I like in every chickenpox patient, they want to admit the patient. Now you guys, you have to understand that every chickenpox patient cannot be admitted, because if you admit chickenpox, all chickenpox, where hell the all other patient would go. So these are the clear indications which patient would require hospital admission with ICU care, and which patient would require only hospital assessment. Okay, so please don't mix up the things and make mistake. I have made it separately because the page students, they do so much of confusion and mistake here. Is this point what I want to make you guys understand is clear? Is it clear?
Yes, ma'am.
Now the hospital assessment will happen in the area where we it has to be taken care not to spread. So the patient should not come in contact with other pregnant women, and consultation would be like with multidisciplinary team where the obstetrician, FMU people, virologist and neonatologist to be informed. This team would be required if the patient is required admission and patient to be hospitalized, so that she should be isolated from others. Now, time and mode of delivery, though most of you know all this. So, depending upon the maternal condition, respiratory physician or intensive care specialist may be involved or may not be involved. Ideally, when the patient is having infection, viremia is going on, that time delivery should not happen. Now, why it should not happen? Because it causes hepatitis, there could be thrombocytopenia, there would be very increased chances of maternal hemorrhage or coagulopathy. This is the reason why the patient, we don't want them to deliver at the time when they're having chickenpox rash or when the viremia is going on. So this is the main reason behind. Okay, this is number one for the mother. Second for the baby would be like when the baby is born, then the in spite of if the patient baby gets antibodies, baby would be at a risk of varicella infection after the baby is born, that is associated with significant morbidity and mortality. And like if the patient is getting delivered during this time, supportive treatment IV acyclovir can be offered so that a patient would recover fast and transfer of protective antibody may occur to baby or fetus. Ideally, if the woman develop rash, then there would be a delivery should be delayed if it is possible by 7 days. That would be necessary. Why? Because of the passive transfer of antibodies. Okay, now it would be clear to you that why we don't want our woman to deliver at the phase of viremia. Now another, if the patient coming to the like pain relief choices, usually general anesthesia we don't want to offer them. Why? Because it affects like it can affect lungs or pneumonia and whatever. So there could be like worsening of the respiratory function in general anesthesia. Even spinal anesthesia is given. Then from the skin lesions, there could be theoretical risk of uh, transferring the virus to the CNS. But epidural considered to be a little safer because in that dura is not penetrated. Okay, so epidural is safe. Now, if the maternal infection occurs in last 4 weeks of pregnancy, there is a risk of varicella infection. So, planned delivery should be avoided 7 days after rash so that the passive transfer of antibodies there. And if the patient has developed chickenpox during pregnancy, neonatologist should be informed so that they can keep watch on the baby. Now, it will be important that how the baby would get it. So, baby can get this from transplacental route, ascending vaginal route, or direct contact with the lesions during and after delivery. If the infection occur less than 4 weeks or 1 to 4 weeks, then 50% of the babies will get infected. They will have varicella infection. 23% of them will get clinical varicella in- despite of having high titers of antibodies from the mother. So baby is at risk. So severe chickenpox infection is most likely to occur if the baby is born within 7 days of onset of mother rash, or mother will develop rash 7 days after the baby is born. In both of the situations, baby would be at risk. Because of that, baby would need to be offered prophylaxis with varicella zoster immunoglobulins, with or without acyclovir. Okay, there had been no change here, but yeah, it would be highlighted and it should be remembered that if the chicken pox happen within 7 days, delivery happens within 7 days of onset of rash, or mother develops rash 7 days after delivery, so baby would be at a risk of having severe infection. So baby should get a prophylaxis. Okay, either with a varicella zoster immunoglobulin, with or without acyclovir. So this part is important because you have to, like, mostly for part 2 people it would be necessary to know. Now, breastfeeding, they can breastfeed if they wish to, but if the active lesions are there near the nipple, so they can express the breast milk. And if the baby is, if the uh, baby is having a, if the baby is receiving treatment, that time expressed breast milk can be given to the baby. Okay, so these were the few updates, and this is the flow chart. So so patient got varicella zoster contact. So if it is first history is taken, if she has no history, if the history is uncertain, if she is from tropical or subtropical country, blood is checked for varicella zoster immuno IgG. If IgG is more than 100, then your patient can be reassured. If it is less than 100, that time we can offer her a post exposure prophylaxis from acyclovir day 7 to day 14 post exposure, if any contraindication. And if the patient doesn't like that, that time varicella zoster immunoglobulin can be given. And patient to be considered infectious 8 to 28 days. And if the patient is susceptible, non-immune, then postpartum varicella immunization to be discussed. That is a new identity in the guideline. If the patient developed chickenpox, then they should be referred to the hospital for the hospital assessment. A severe infection, intravenous acyclovir can be given. Baby, if the seroconversion occurs less than 28 weeks, less than 1% of the baby may have fetal varicella syndrome. So they should be referred to the fetal medicine unit at 16 to 20 weeks or 5 weeks to for the detailed discussion and the scan. Consideration for immunocentesis can be done. Now, so this is the summary. Now, if the patient develops chickenpox, she should avoid contact with the susceptible people. Symptomatic treatment to be given for, and the hygiene maintenance. And if she is present within first 24 hours of the rash and she is more than 20 weeks of pregnancy, acyclovir 800 milligram 5 times daily for 7 days can be given. And if she is less than 20 weeks, then also consideration for acyclovir can be done. And ideally at the time, if the delivery is near and the patient develops chickenpox, so usually the delivery to be delayed by 7 days. Okay, so this is the summary. So that's all I have to speak about and the new updates there. So now any one of you have got any question can ask me.
Yes,
Otherwise,
yeah.
yes.
Just I have a question about the breastfeeding in comparing herpes zoster with herpes simplex virus. Because last lecture when you explained about herpes simplex virus, I remember we should not only express, I think we should discard the breast milk in herpes zoster simplex. I'm confusing about both herpes simplex and herpes zoster in case of breastfeeding.
Okay, in in like herpes simplex, uh, again the same thing was there. They were saying to if they have lesion around the breast, they should not breastfeed.
Yeah.
But the expression of milk was not there, and they wanted to keep a hand hygiene. But in chicken pox, if the patient is having like expressed milk can be given if the baby is receiving if the baby is receiving prophylaxis already, because that time if any transfer occur by the by the breast milk, then it will be taken care of because the baby would be on uh, already getting the prophylactic doses.
You mean baby on a cyclover, or you mean because
Yes.
mother immunity?
See,
Hmm.
basically it is if the like uh, if chickenpox infection occurs around the time of breastfeed. If it has occurred previously, then there is no issue. But around the delivery or around the breastfeeding, if the chicken pox is there, that time, what they say that if the baby chicken pox happened within 7 days or of delivery or after that, that time baby would be at high risk. That time they would uh, review the baby, and they will consider giving the baby varicella zoster immunoglobulins and acyclovir. In that
Mm.
situation, baby is getting prophylaxis, so
Yeah.
expressed breast milk can be given.
Yeah. Okay.
Okay.
Yeah.
Yeah.
Thank you.
Madam, I have a question.
Hmm. Yes.
You have said that if the chicken pox occur in pregnancy, suppose at 16 weeks or 18 weeks, we have to defer the ultrasound up to 5 weeks. Refer her to the
Ye-
fetal medicine unit.
Yes.
Madam, like an anomaly scan will be done at 20 weeks, 18 to 20 weeks. If
Hmm.
suppose at that time she got infection, so I have to do the scan at about 25 weeks. I'm just confused about
Okay.
that.
Yeah, I'll tell you. See,
Yes, ma'am.
now if the patient got, let us discuss with the two scenario. Now, if
G,
your patient is getting infection around about 12, 14 weeks of pregnancy,
exactly, ma'am.
okay. That time if she is getting infection, that time if the virus has reached to baby, it will cause some damage, and you have to detect it on scan and whatever. But
Yes,
that
ma'am.
time it will take 5 weeks. So if
Yes,
she
it is
gets
mentioned in the guideline. Yes.
yes, so if she gets infection around 12 to 14 weeks, you add 5 there, 5 weeks. So you can send her to varicella. You can send her to fetal medicine unit by 19 20 weeks of pregnancy. Nothing would happen. So your her anomaly scan and her amniocentesis is coinciding. Now second scenario, your patient is at 20 weeks and she gets chickenpox infection. Okay, but at 20 weeks, if she's getting chickenpox, her anomaly scan would be done that time. But now we get to know whether the baby developed fetal varicella syndrome or not. So from her infection, after 5 weeks, she will be sent to the fetal
For the,
medicine unit. Yes.
for the ultrasound.
So if she develops at 20 weeks, she will be sent
Uh,
around about 25 weeks. That
For
time
the
again, yes, for the fetal varicella syndrome.
madam, and again, amniocentesis, when will we do?
Amniocentesis usually whenever an infection occurs and the virus reaches to amniotic fluid, it will take time. It will take time. So
Yes,
in
ma'am.
first infection and getting all scan done and getting viral DNA from amniotic fluid, it will take in between of 5 weeks.
So, ma'am, amniocentesis is also done after 5 weeks almost to detect
Yes,
the.
before that they will not be able to detect that DNA PCR.
Yes, ma'am. Basically, the question asked from this stem, the ultrasound, when will we do the ultrasound for detection, and
Five
also
weeks.
for And this 5 weeks. And for the amniocentesis, we also same 5 weeks.
Yes, yes, yes. So
Yes,
see,
ma'am.
when the patient develops it, 5 weeks later on, they will go to fetal medicine unit, and there the fetal medicine specialist, they will do the detailed discussion about whole chickenpox history. That time the
Yes.
scan will be done. That time they will discuss with the patient whether they want to go for immunocentesis to get
Or not.
to know
Okay.
whether the baby got affected or not. Many of the
Yes.
parents will agree, and many of the parents will not agree, because
Right,
if
ma'am.
they
I
find,
thought
yeah,
if first of all we go for the ultrasound, then after we decide for the amniocentesis. Because
yes,
I'm so much confused between these. Thank you so much. Because maybe question come from in this in the exam like that.
yes,
Thank
yes,
you.
yes, it can come. And like when the immunosynthesis is done, if they are able to get DNA PCR for this virus, that time they like there could be possibility baby maybe get affected, may not be get affected. So it has poor predictive positive predictive value. But if they didn't get DNA PCR, then we are very happy.
Negative.
That means we
Yes.
are sure, because negative predictive value is very high.
Very high. Yes, ma'am. Thank you so much, madam.
Okay, few questions. Only for a few questions are there, maybe for next 5 minutes. So what? So these are the options. What would be the most appropriate management? A woman at 22 weeks admitted to antenatal ward with antenatal hemorrhage. Whether she was in department, she was got a contact with a baby with a chickenpox rash. The test shows she's non-immune to varicella zoster. So what will be the choice?
I.
Yes, I. Though it is the acyclovir 4 times daily, 7 to 14 days of exposure. Though this question is from the old book, but I have changed the option according to new guideline.
Madam, can we give this patient Vasusta immunoglobulins as well as a
It
if
it
he
can be given, but second choice according to new
yes,
guideline.
if he doesn't want acyclovir, we can give because
Yes,
immunoglobulins can be given after the rash.
it can.
Very serious. Yes.
Oh God, immunoglobulin cannot be given after the rash. Please understand. I highlighted this 2 3 times. Immunoglobulins has got no role once the chickenpox rash is there.
No, madam, sorry. If he got the symptoms, sorry, symptom, not the symptom, his history of contact, and he's zero negative for the varicella zoster,
Yes,
then we can give.
yes. If the patient is negative, I'm repeating it
Yes,
again. So
yes,
first
madam.
choice will be oral acyclovir or valacyclovir. But this is the first choice according to this guideline. But if
Later,
the patient doesn't want oral treatment, or if the patient has got some like contraindication
later,
to acyclovir, that time or varicella zoster immunoglobulin injection would be given.
right.
So patient has 39 weeks, developed shingles from a child from a chicken pox. She has a vaginal birth 3 days back with a baby boy born. What will be the management for the baby?
I'm Seema. No risk.
Yes, very nice. Because shingles means the secondary infection. That means the baby would get protective antibiotics from the mother, so nothing is required. Just reassure. Okay, now a woman delivers a baby girl at 20 weeks. She developed chickenpox 3 days post delivery. Now, 3 days post delivery. So, baby is at risk. So, what will be the risk? What will be the management for the baby?
IV cyclovir
Why IBI cyclovir?
for the baby.
Why?
I'm B, ma'am. Administer these at
Immuno-
IG as soon as possible.
Better answer than that?
And monitor for 28 days after administration.
Very
That, ma'am?
nice.
H.
Yes.
Okay.
H.
Yes.
Give the baby a cyclovir injection, because
Mm.
I told in the last slide that if the
Mm.
baby delivers within 7 days of mother having rash, or once the delivery is there and mother develops rash after 7 days. So both time for the baby high risk. So baby would get a prophylaxis. So either with the varicella zoster immunoglobulin plus minus acyclovir and monitoring for 28 days. Here we are not saying 8 to 28 or 8 to 21 because mother is baby is all the time with mother.
Madam, so if we want to give acyclovir plus minus, so we will give her oral or IV?
In that situation, it would be IV only because
Yes, ma'am.
baby born, just
Yes,
born, cannot take oral.
right.
Okay, and it is not mentioned. The route was not mentioned in the guideline. I looked for it very carefully because of this question. But for the
Right.
baby just born, cannot take oral. Okay, so so here, so the 37-year-old woman seen by the GP with the chicken pox, she developed rash 18 hours ago. She is smoker throughout pregnancy, and she is currently 22 weeks. No signs of chest infection, no systemic symptoms. What you will do?
Refer to the hospital for assessment. Yes, I think.
Very good. So here the patient would require treatment with acyclovir, and because she is in the second half of her pregnancy, okay, so hospital assessment. So 25-year-old woman who has gestational diabetes booked for induction of labor, but midwife today saw that she had rash, typical of chickenpox. So what you will do?
Ma'am, yes, defer delivery by 7 days.
Yes, so delivery or induction of labor to be deferred by 7 days because that time would be required for passive transfer of antibodies from mother to baby. 22-year-old woman seronegative for chickenpox and contact with the chickenpox in the school. She was given varicella zoster immunoglobulin today and on day 5 after exposure. Already been given.
And Madam N, when
What is an? Yes, very nice. So she should be infectious from 8 to 28 days. A primary Gravida nursery teacher went into spontaneous labor 39 weeks. She has one child who had chickenpox. She herself had chickenpox from her mother.
Reassurance.
Hmm? The, what is the answer? She herself, she herself never had chickenpox.
yes, so I have to check for the immunity. Yeah, but now she
She
is
had
delivered.
no, no, no. The patient is in a spontaneous labor. She had chickenpox exposure some days before. She herself never had chickenpox. So there should be like checking for the varicella zoster immunity. Either the answer would be E, or after that, if it is negative, then acyclovir from 7 to 14 days of exposure.
Most required.
30-year-old primary school teacher, 12 weeks with fever, generalized rash, malaise, muscle ache, feeling feverish headaches. Or during assessment, she has a contact with one children who had chickenpox. She has maculopapular rash. The chest appearance is typical of chickenpox. What you will do?
Feed cyclovir IV.
Why have we gone for the ultrasound for fetal
Fever,
varicella?
malaise, muscle ache, feverish
Symptom.
headache. But she's not having a severe kind of chickenpox. No, no drowsiness, like CNS symptoms are not there, lung symptoms are not there, hepatitis symptoms are not there, so admission would not be required.
Right.
Okay, so here you will give her oral treatment and you will refer her to the FME after 4 weeks, 5 weeks time. So hospital admission is only done, as I already told, if the patient has hepatitis infection, if the patient has pneumonia, or if the patient has dense bleeding rash, or like photophobia, seizure, encephalitis, all kind of symptoms are there. That time the patient would require admission in the hospital with ICU. Okay, here it is this question just gives us the description of general features of chickenpox. Is that clear why the answer is not IV immunoglobulin,
Yes, doctor.
IV is Eclivir?
Yeah,
Yeah,
yeah.
so to judge from the question, this is the in these questions, mostly the people will do mistake when to admit, when not to admit. You should have a very clear idea. So 31-year-old woman at 12 weeks of gestation, she exposed to someone with chicken pox. She's from tropical country, can't remember chicken whether she have it or not. Very easy. What is the next
E.
step?
Blood test
E,
to
That is good. Yeah.
blood
mm,
test. You have to check the
determine
blood.
immunity. Mm.
So 26-year-old woman seronegative for antibodies contacts GP because she has contact with chickenpox. She is now 20 weeks. She is seronegative and she has exposure. What to be given? Repeat question.
Orally cyclover 800
And
mg.
Madam, fetal
and
medicine unit you at in
Mm.
5 weeks.
Yes, ma'am. Mm.
acyclovir
Encyclopedia.
should be from 7th day to 14th day of exposure, and after 5 weeks she should be referred to the fetal medicine unit. Okay, that's all. Thanks for joining. Anyone of you have
Thank
got
you.
any questions?
Thank you so much, madam.
Okay, welcome. All the best for your exams. Hysteroscopic guideline class, I think I would be taking next week. So all new guideline classes are done. Bye, people. Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Madam, you have